Hi, Amy Rush from Perth, Western Australia. I'm from the Type 1 Diabetes Family Centre. My question's for Caryn. Going back to your high carb, low carb athlete comparison study showing that the glycogen stores were the same, does this refute the allegations that with low carb diets you would become chronically glycogen deplete?
Hi, Amy.
Hi, Caryn.
So just to rephrase, are you saying that in the mainstream situation you get carbohydrate, you get muscle glycogen depletion? Are you saying would you get muscle glycogen depletion in this state as well?
Well, your graphs were awesome. It showed that there is really
they weren't mine.
Well, whoever's they were, showed that there really was no difference. So straight away I was like, well, if there's no difference, what is all this talk about going low carb, your glycogen replete? I'm looking at it in terms of type 1 diabetes and hypo and things like that.
Yeah, so you do get, because of gluconeogenesis, you do get synthesis of glucose. So while you do get glycogen depletion, you get repletion by not having to eat the carbohydrates. So I think that makes amazing sense, particularly for type 1s, because there's less work you have to do.
Which was why I was super happy to see those.
Yeah, and that's why I also think that people think that type 1 is so different to type 2, and essentially it is, but when it comes to management of low carb, I don't see why it should be it's okay for type 2, 1. I see it as very, very similar. You just have to have a slightly closer eye on it.
Thank you, Caryn. Thanks.
All right, over here to the right.
Sean Christopherson, family doctor from Sydney in Australia. My question is primarily for Dr. Westman, but please jump in, tap the expertise of anyone else on the panel. Quite a few people find on low carb, keto and fasting that their serum uric acid improves greatly, and so it should because it's a soft marker for the metabolic syndrome. But I have a cohort of patients whose serum uric acid has actually jumped up, and a number of them have had gout attacks. They love the lifestyle and are determined to stay on it. And so I wonder what you would do in those circumstances, whether you would play with the macros or start them on allopurinol, or what would you do?
And at what stage are they in the diet change? So
some of them are 3, 6 months into it, others are 12 months into it. And some are doing keto, and others are experimenting with fasting. And I understand the uric acid rise is 2 separate mechanisms for those.
And are they still in the metabolic syndrome? They have more weight to lose?
Their other soft markers have improved, so their HDL has gone up. And
no, but is the BMI still high?
Yes.
Okay,
yes.
Thank you.
Yep.
There are some issues with uric acid early on. As your ketone levels go up, you can actually have uric acid go up initially, and I'll explain to people I might give you a gout flare. So in someone with a history of gout problems, I'll make sure they get treatment quickly or know how to get treatment for it. Most often you get through the gout flare and there's not an issue ongoing. But if you're still in the metabolic syndrome, you may have elevated uric acid and an issue with gout, and I would just keep treating the gout as you lower the root cause, which is the metabolic syndrome and that abdominal obesity. And the reason I asked about weight is that sometimes it takes years for that to actually resolve, and not just gout, but then blood pressure, diabetes, all these other metabolic issues don't get better until you're at almost your high school, college weight, university weight. So wait it out.
Okay, thank you very much.
Of course.
Can I just add something to that? I see that a little bit in my clinic as well, and from a physiological perspective, I believe that with high ketones and uric acid do compete for excretion. Yes. And what I would potentially do, you've got 2 options. You can either medicate for gout, or maybe being in a state of ketosis that's not necessarily that deep. So you've got slightly lower circulating ketones, and you might have a positive effect on the uric acid. So I think, with weight loss, whatever, you can still do it on low carb and mild ketogenic diet as opposed to deep ketosis. So that's what I play around with, and I find that works.
Okay, thank you very much.
Thank you. Yes, ma'am.
Donna Johnson from Colorado Springs. My question's for Dave. Given that our insulin response to food seems to be as important, maybe more than our glucose response, do you think that insulin meters are in our future?
You have no idea how many conversations I've had of, in many respects, pleading many different people to take this up. Certainly a home insulin test, I think, would be such a game changer, really, for the Western world.
Yes.
Now, naturally, I'm a geek, and I just can't wait until we can have a continuous insulin monitor. But truly, I think that it really can't quite be understated that Joseph Kraft was part of what set the tone going all the way back to the 70s, and he was quite prescient then. And we certainly have all seen this for ourselves, just how relevant it is to see lower and lower insulin and what that means to our overall health. And by the way, this doesn't just apply to low carb. This can also apply if you're on a carb-centric diet. If you still have good insulin sensitivity and you manage it well, that's great. But why not go and have a monitor for it? Because glucose, I don't think, is anywhere close to as prominent and as useful a marker as insulin is.
Thank you.
Thank you.
Hi.
Yes.
Can you hear me? Because the mic is up there. And I go okay? So this question is for Dr. Westman. I'm Leela. I'm a pediatric nurse practitioner here at Children's Hospital Colorado, and I work in otolaryngology. And while Colorado has a lower incidence rate of obesity, we still are seeing many obese kids who come in with obstructive sleep apnea. And so, you know, we explain to the parents that we can take out the tonsils and the adenoids if they're enlarged, but it's likely not going to cure them, and we've got all these kids on CPAP. We refer them to lifestyle management, where they are still doing a low-fat, high-carb diet. How?
What hospital again?
Children's Hospital Colorado in Aurora, right down.
Yeah, I'm not surprised.
How can we change it? It makes me crazy.
Well, it's interesting. Colorado, tooting the horn of the research from Colorado, Jim Hill has been here and really was in the exercise, low-fat paradigm. And I think everyone who loves to exercise has already moved to Colorado, yeah. Which biases the Southern California and Colorado are kind of anomalies in the obesity epidemic we have. So yeah, most programs, even in hospitals, are not aware of this. More and more, they're getting more interested, and the idea of hospitals and clinics doing this is fantastic. Try to share in your own world how to do that. Now, children with sleep apnea and children with diabetes, this is brand new, right? Mm-hmm. Even at Duke, they didn't have a pediatric diabetes program until 15 years ago, and this was a referral center, and now diabetes, sleep apnea is everywhere. Treating sleep apnea with any weight loss program will generally fix it. And yet you go to sleep apnea experts and they'll say, no, you can't fix it. Well, yes, you actually can. And there's that kind of, do I really want to tell someone how to fix something I'm treating them for, and then they won't come back? And so you got to get outside that financial thing. So low carb among children, keto is fantastic. I think it's just eating real food. And there are a couple books out there. If you search for low carb children, LCHF, I think Jamie Bales in West Virginia, Fred Pescatore in New York City, both have books on that.
Mm-hmm. And you said James Hill, was that the name of the researcher?
Well, James Hill is I'm nodding to one of my teachers in the obesity medicine world. He has no clue about this area unless he's gotten some education recently. So the traditional focus in Denver, where he has been on the low-fat exercises fixes everything, which is why everyone who exercises has moved to Denver and to Colorado. Right. Get what I'm saying? Yeah. So Jim has done great work in the obesity medicine field, but doesn't understand this last time I talked to him.
Okay.
Thank you.
This is Gloria, and I live here in Colorado. I have a question related to my observations in how differently my husband and I react to what we do, which is low carb, keto, and then for the last 6 months or so, pretty much carnivore. When we started to intermittent fast about 3 years ago, I dropped 10 extra pounds, and he dropped 15 or something, and he has gotten all of it back. with no explanation. I cooked for him, or grilled for him, I should say, and I don't know how to explain that. My weight is super stable, and I guess my question is, could this be related to those maybe intrinsic differences between males and females? Or I just don't know how to explain it, or should I just leave him alone and assume that, you know, he's technically metabolically healthy, but he has those 15 pounds that he would love to get rid of, and he doesn't know I'm asking the question, so.
So I had a little trouble hearing. So the differences between men and women, it was one issue. Yeah, that's a big issue, and I think on average men do lose faster, although even accounting for the heavier weight that most men have. But now in terms of regaining weight while fasting, was that the question?
Intermittent fasting.
Intermittent fasting.
Yeah.
So intermittent fasting to me, if you're doing a keto diet and you're not hungry, is fantastic. So the NIH, the governmental researchers are studying intermittent fasting using high carb diets.
No.
And they were presented the details at the Obesity Medicine Association recently, and they were saying, well, the intermittent fasting doesn't work well, but they were studying high carb diets, so because there's hunger. So in the context of a keto diet, if you're not hungry and you eat once a day and call it intermittent fasting, I'm all for it. I don't like the idea. My teaching, and I think Mike may echo this, is to listen to your body signals and don't power through hours of hunger and say, I'm intermittent fasting, and that, you know, you want to work in concert with how your body is telling you to eat. So that I know there's a lot of confusion of what does intermittent fasting mean, and there are different hours and all this.
Yeah.
I have no research experience with that, and I don't use that clinically.
Yeah.
Any other comments about fasting? General?
Hi, from a research perspective, males tend to get researched more. So there's very little about the difference between males and females. Females have got something called a menstrual cycle, and that adds a whole lot of complication. And that's one of the reasons why we are not studied, but we need to know more in that area. I think, you know, when it comes to intermittent fasting, people really need to listen to their body and know their limits, because sometimes people fast and then don't realize that they overeat afterwards, and that can upset the balance as well. So I think fasting is great. I think it definitely has its purpose, but it's about listening to the body and being cautious at times.
Yeah, that's not the case, overeating. And then something I've observed as well is that his numbers, you know, the markers for health, they do not budge very much at all, whereas mine are extreme. They go to very good places, and his are not moving. We're eating the same. We're sleeping the same. I don't know. It's interesting to observe, and I don't know what the deal is with that.
Yeah, so you know, this is a case for a coach, a program. I've had spouses who think they know what the other spouse is doing, but when they're not at home, you know, they might sneak a carb in, you know. And so anyway, then one wife actually wanted to start checking his ketones then. You know, that's one way, you know, but this is a pretty detailed conversation. Sorry, we can't really answer that.
I know, but thank you so much.
Thank you.
Actually, I want to just add real quick. For anybody else in this room, one of my favorite just brainless devices is a continuous glucose monitor. The reason is for those people who may not even realize that they have leaks, it pops up all the time. So for those tough cases that I've had in my own family, I've always pushed for them to get one, and its success level is just incredible. So per what you were just talking about, I mean, it's one of the best ways that you can find out for yourself.
That would detect your spouse eating carbs.
And yes, and yourself, in case you might be doing it and not knowing it.
Hi. Oh, can you hear me? I have the opposite problem. It's a little too short. My name's Evelyn Kessner, and my question stems from Caryn's presentation, where you mentioned that you've used keto to treat concussed athletes and seen success with that. Could you please elaborate on that?
I can. I thinking of one athlete in particular. She had quite severe concussion for about 9 months, and she happened to be an ex-student and an ex-client of mine in my low-fat days. And she contacted me one day and said, hey, do you think you can help me? I've got concussion, I haven't been working for 9 months. I'm like, sure, come in. And again, it's all experimentation, but we know that keto is neuroprotective in some way. We know that keto is not harmful, but potentially can be beneficial. So we put her on keto, and honestly, within 2 or 3 weeks, she was a different person. She used to nap every single day, 3 or 4 times. She was not napping. She could actually function with her children. Then we played around a little bit with MCT oil, with a little bit with exogenous ketones, because we wanted to get her in deep ketosis. And basically, she found her way, and it ended up being her sweet spot was really intermittent fasting all day, apart from maybe, if she feels a little bit hungry, maybe a few nuts here and there, and then having a good quality low-carb meal at night. And then when she got a job, so her life's totally back on track. And when she had an important business meeting, she'd just throw in some exogenous ketones, because they are quite expensive. So she had a really healthy mix of intermittent fasting, keto, and then the biohacking that goes with it. And that is an absolute N=1, because I know that there are hundreds of others who haven't had success with keto. I know we've actually got a PhD student that is looking at concussion in general, and I'm persuading him to add a study about keto, and he's almost convinced, but I definitely think that there's something there that needs to be fleshed out in research. So if anyone from rugby has any money and wants to throw it our way, we're happy to do the research.
Thank you.
Thanks.
Hi, my name is Josie. I'm an occupational therapist from Washington State, and I have a question that might ultimately turn into a pitch to talk more in depth with Dave later in regards. My question is about the culture of research methodology in the medical community, broad and wide. I personally have a background investigating evolutionary theory and animal behavior as an undergrad, and I feel very fortunate as a clinician that my field and my education focuses on producing consistent, reliable functional outcomes for non-standard populations, which tend to be assumed to be accepted and not fitting normalized statistical models in determining efficacy of interventions. And I feel that my background has given me a pretty comprehensive training in how to assess through a scientifically literate perspective and evaluate the types of claims that can be deduced from different research methodologies. Interacting with the medical community by and large outside of my field, I'm starting to suspect that there may not be as much exposure to non-traditional research methodologies, or even maybe the epistemological conversations to have about how you can deduce claims from what typical designs and how you can infer them theoretically within a scientific model. This is very roundabout, but I'm noticing a lot of the barriers that this intervention is interfacing with is because it's coming in conflict with claims that depend largely on normative statistical distributions or research methodologies that are ill-equipped to produce philosophically justifiable claims. So my question and probably call to action is how can we increase awareness of appropriate research methodologies or critical appraisal within the medical community so that we can produce effective and functional interventions for our clients.
We can keep our Zoe Harcombe to do amazing blogs at how to critique science.
That's a good one. Just reflecting on the last 20 years, I went to ask Dr. Atkins for money in this space because no one would fund this. There was a taboo on funding high-fat diets because you can't tell people to eat fat. I mean, you'll kill them. That was 20 years ago. The NIH had no, in fact, this NIH is the largest governmental research funding organization in the US, probably in the world. There were people in the exercise world saying we would never fund an Atkins diet study. So, okay, go to the doctor who who is doing it, and no one had ever asked Dr. Atkins to do research. And so then when we went to publish the paper, the reviews were, we can't publish a paper funded by a doctor. So the Atkins Foundation was created, and I got research money from the Atkins Foundation, and I think then the downturn in the economy made it so that they didn't have any money to fund, and that's one reason why I went into the clinical setting using what I had learned. To my knowledge today, the largest studies being done that we've seen at this meeting are funded by individuals who have a lot of money, who are funding foundations, not the NIH. And there are two people within the NIH system that I'm aware of. There are now people have learned to code the study. It's not low carb or keto. It's, individual differences in diets, blah, blah, blah. So that the people who are just superficially looking and can't study that can't. I'm happy to share with you the people I know within the system. So, a good way to get it, if you are a researcher, is to get a K award, which is a lower bar of requirement for evidence. The old joke is that to get an NIH study, you already have to have proven what you say you're going to prove. They don't want to take any risk on anything. And so that's a big issue. There is a little bit of change there, but and also at this meeting, we've noticed that a new company based on low carb principles got the money, raised the money to do their own study. And now I know that's going to come into criticism by the other people saying it's funded by a company, but who else is going to do it? I mean, and this has been 20 years. I'm not talking about complaining today about the last 6 months. This is 20 years.
Good science doesn't have to be expensive. The methodology needs to be robust. So emphasizing that focus, I just want to implore looking at other rehabilitative sciences and their models of funding. I am not contingent on big pharma. I'm held accountable to producing functional outcomes consistently for non-standard populations, and I'm held scientifically accountable. So there may be some models and even funding models that have been emerged in other medical markets. So I just encourage interprofessional collaboration on this.
I just want to comment briefly. I think the big issue is this reliance on observational statistical studies, which is, of course, the cheapest and easiest way by far to do nutritional research, but it doesn't really prove anything. It mostly just puts up a hypothesis that can then be tested. But that's not the message you get in the media, and even experts rely quite a bit on these studies that are fundamentally unable to answer the questions we're asking. And I think really the hard truth is that to know the answers to these crucial questions about what kind of effect do you get from eating certain kinds of foods, they require very big, very, very expensive, long studies to actually answer them. But these are crucial questions that touch upon the health and well-being of 1 billion people or more. We should spend that money. We should just realize that it's necessary. So it's going to cost billions, but it has to be done to know. Otherwise, we don't know.
It's absolutely true, and obviously I'm very vocal on this. You have to get something like a randomized control trial to get to like this certain level of evidence that many people are going to say is all that they're willing to look at. The irony that I find is that many of those same people who advocate on that side of it, for example, stand behind the nutrition guidelines. It astonishes me. It honestly does. A lot of people comment on how much I put into work, like the presentation I just gave. Not only was I eating exactly the same food, I was eating at exactly the same times in order to reduce all of those confounders. And while that may seem to a lot of you like it's very extensive work that I'm doing, for me it's barely adequate. Like, I feel like to get to these kinds of levels where I can really isolate out the variables, that's what it's going to take. But I don't have any letters after my name. I'm up on the stage strictly from data. You could say sweat equity. My wife would say blood equity.
Have any of you guys heard of a single subject ABAC research design? with any accountability, that research methodology is dominating the world of autism-based behavioral resources. It's pulverizing the markets of other therapeutic out because of the robust evidence of that specific non-parametric, non-standard population, intervention-based research design. They've effectively advocated with the Supreme Courts of several states in order to get insurances to reimburse that mode of therapy. I feel like if that design is not being given a fair appraisal in the medical community, it's doing a disservice to so many populations. So anybody who wants to discuss this further or awareness of other therapeutic research methodologies, I look forward to having a better conversation about what this could look like.
That's good. Keep it up. Keep it up. We need the connective tissue that's going to help us explore new ways of thinking. Because I think if there's anything we can all agree on, a lot of how we're here today didn't come from the guidelines. They came from finding answers on our own, not through traditional means.
Thank you.
Hi, I'm Joel from Boulder, Colorado. The microphone is just right. I'm a strength athlete, and this question is for Dr. Zinn. I noticed that you said that strength athletes don't really benefit from a low-carb diet, and so I'm just curious about that. My own experience, I eat mostly low-carb, but a lot of gummy bears right around the workout time, so.
Okay, hi. I do want to clarify that I did not say that strength athletes don't benefit from a low-carb diet. All athletes can benefit from a low-carb diet. I did say that I would not necessarily put them on a keto diet. I would probably start with a moderate reduction of carbs, somewhere around 100 or 150 grams. In saying that, that spectrum that I put up is not set in stone. And if a strength athlete came to me and said, I want to try keto, you would absolutely do that and support it. There is no evidence, to my knowledge, about keto weight gain strength as a what am I trying to say? A line of inquiry. But it's about playing around. I know, in fact, I talked to one at registrations, a powerlifter who is doing keto and doing beautifully at it. So that's where I would start with a strength athlete. It's also got a little bit to do with the amount of protein that you give an athlete. For some athletes, too much protein might prevent them from getting into the level of ketosis that they want. And of course, for strength athletes, you need optimal protein. So it's a fine balance, but I do want to end this by saying that low-carb diets are definitely good for strength athletes.
Thanks.
I'd like to just add that I get a lot of questions, does the clinical program that we use work for athletes and all that? And the metaphor I use is that when you do a low-carb keto diet, ad lib, that just real foods, it's kind of like getting into a car. You start it and you go. But if you're going to do elite athlete or just you're an athlete, you want to optimize what you're doing, it's more like getting into a plane where you look at the wings, you make sure you check some things. It's not quite as simple as just doing it, and you may add back carbs. God forbid, during the race and all that. So if someone asks me about that, I refer to the experts in exercise.
Thanks.
And my question is for Mike Eades. I really like the way the experiments and mechanisms that you brought demonstrate how fiber is really merely a marker of the level of processing of carbohydrate foods, and that really neatly explains some of the epidemiological data that people are tripping over. And I'm wondering, my question is whether you've encountered any evidence about processing effects or on incretin in protein foods?
The question was, did I look at that in protein foods, or did I encounter that in protein foods?
Yes.
Yeah, I did. And the only thing that really has made a difference is hydrolyzed protein, which is kind of pre-digested protein. And even that is not a lot. Even powdered protein, whey protein, you know, chopped up meat, ground beef versus steak, it doesn't seem to make a big difference. And I mean, this whole field is ripe for exploration. I mean, the things that I showed where they're giving people these nasty fats, the, you know, intralipid and that other thing, which was the corn oil. As far as I can find, nobody's looked at monounsaturated fat. Nobody's looked at saturated fat. Nobody's really looked at a lot of this thing. I mean, this is a wide open field right now. But based on what I found, and I went through a lot of papers, I didn't see anything on protein because I wanted to present carbs, protein, and fat. And I just couldn't find anything on the protein other than the hydrolyzed protein causing a little blip up, but not much. And as draconian as Jeff was with the time, I didn't want to spend any time on anything that wasn't of value to the entire audience.
Okay, thank you. Yeah, my suspicion is that the effects are mostly going to be about the carbohydrate.
Yeah, about the structure and carbohydrates and the carbohydrate-fat combination.
Thank you.
Mm-hmm.
Hi, I'm John Moz. I'm from Prescott, Arizona. I work as a physical therapist. I want to direct this to Dr. Zinn. I work fairly closely with a very high-level rock climber, specifically boulderer. Noting that both in training, a lot of weightlifting, and then training actually doing the bouldering, all the benefits of ketosis, the more he's in ketosis, the better he does. And one specifically is whether it's motor sequencing or when you're doing bouldering, just seeing the holds better. He is astounded at how much better. And if he goes off of his keto and he gets a little carb fog, so he says, he has a terrible day when he's trying to boulder. But when he's strictly on the keto, that's one of the benefits he sees, as well as better energy, good power. Probably he can hold the holds longer, less lactate buildup, and less muscle fatigue. So I thought I'd just mention that.
That is a perfect example of working it out for yourself. And there's no way I would say to him, I think you need more carbs. So, you know, keto is neuroprotective. He's getting that clarity. He's getting the micro clarity that he needs. He's feeling amazing. His performance is increasing. Why would you change that?
Thanks.
Interesting. Sorry, this is an interesting sequence because my name is Andrea Cofield. I'm a technical rock climber from Valley Forge, Pennsylvania. We do have world-class crags on the East Coast. However, I do love me some desert sandstone. But I'm 6 months keto and seeing undeniable benefits on so many dimensions. I can't imagine going back. However, I'm having difficulty getting back to the level of training and performance that I knew pre-keto. So the question is coming. I was lucky enough to find a GP in my hometown, thanks to the links to databases. It was either Diet Doctor or Denver's Diet Doctor. Thank you for those resources. Is there a similar easy way to find a physical, a trainer or a sports nutritionist that would also work with me from a ketogenic paradigm?
Yeah.
Without going to Maui, right?
Yeah, well, you know, in this day and age, we do Skype, we work on Zoom. People, there are dietitians all over the world that are doing Skype consultations.
Sure.
And again, it sounds like a classic example of, how long did you say you were doing keto for?
6 months.
Yeah, so you know, you might not be fully fat adapted yet, so you might need to just hang in there until that peak performance comes back, or you might need to introduce a subtle amounts of carbs so that you don't lose the effect of being in ketosis, but achieve the improvement in how you feel. But honestly, there are plenty of people out there, either face-to-face or online, that are able to help and are willing to help.
How would I find them, though?
So you can find those people by Google.
Well,
I'm just joking.
I mean, I can call them one at a time.
So, I mean, the people that I've seen give talks and have been in it a while, Zach Bitter, zachbitter.com, holds the 100-mile race record. Okay. Did you know that there's a race to run 100 miles?
Yeah.
I mean, he's great. He's spoken at these kinds of conferences. And also vespapower.com. They sell a product, but they also give a lot of information and do coaching there. I want to point out Serial Killers. It's a movie not S-E-R, it's C-E-R-E-A-L, Serial Killers and Serial Killers 2 have excellent information about exercise and athletic performance and how it took over 6 months with monitoring of oxygen and fat optimization for Sami Inkinen and his wife to row in a rowboat from San Francisco to Hawaii, and they broke the world record by 15 days. And great films, Donald O'Neill, maker of those films, and Troff Noakes and Steve Finney, you get to visit all those people too. Great films, Serial Killers 2, and that's on that thing called Netflix, I think, anyway.
Okay, thank you.
And Diet Doctor, dietdoctor.com too? Okay, thank you.
Okay.
Thanks.
I'm Ed Hendrix. I'm an obesity medicine specialist from Sacramento, California. I've been putting patients on, of course, I'm a physician, and I've been putting patients on ketogenic diets to treat obesity and metabolic syndrome and all the various things for 30 years. So my question has to do with, I'd like the speakers to address sustainability. From my perspective, that means maintenance of weight loss and success at reversing diabetes and metabolic syndrome. And a few years back, 2011, Eric Westman helped me put together a study in my own practice, and we published a paper on 300 patients who were on ketogenic diets. And now the paper never mentions the word keto because we wanted it to be published in the obesity journal. I was afraid that would kick it out of consideration. But the patients, if you read the methods, you could see that patients were actually on ketogenic diets, and we focused on using one of the medications, phentermine, to help them do it. And what we found was that the ones on phentermine lost a little bit more weight than the ones not on phentermine, but the real difference came in maintenance, and the ones that continued to take phentermine for maintenance averaged about a 15% weight loss even out to 5 years. So I'm asking the speakers to address that idea of what are the best ideas for maintenance or sustainability, and what do you think about using medications to help with maintenance and sustainability?
Thanks, Ed, and you are one of my teachers from the Obesity Medicine Association. I was waiting for you to say, and I taught Eric everything he knows. Well, in terms of phentermine, so there are medications that can be helpful as adjuncts to diet therapy, no question. And I mean, I find that it's easier and easier to be sustainable, do this a long time as several things change. One is the availability of low-carb foods and low-carb friendly restaurants, families, things like that. And then also the lack of resistance from the medical mainstream. It's a big change from just 5 years ago that you don't go to a doctor and say, the doctor doesn't say, oh, don't do that, it's going to kill you. What people tell me is more, well, I can't really endorse that yet, but don't tell me what you're doing, everything looks great. So I think there is a role for medication, but I'm hopeful that the diet change can be sustainable as these barriers go down as well.
Actually, could I add to that real quick? I don't have a clinic, but I do have family and friends who have also jumped into keto. The single biggest reason why there ends up being a lack of sustainability with some of the challenge cases has almost invariably been the same thing, which is they're very militant about being keto at the beginning, and then they relax the carbs just like a little bit from their perspective. From their perspective, now they're adding taco shells, it's not a big deal, and their other friend who's on keto seems to be doing well by adding the buns back in. So maybe they're just going to do it, and they only do it like, 2 or 3 times a week, something along those lines. And pretty quickly it adds up for those people who are, of course, very far down the road of insulin resistance, and they do have individual needs where they need to be at those levels. So a lot of times people call it carb creep or carb leaks or something along those lines. I really think this gets underestimated a lot, even within the low-carb community, is that oftentimes the gains you're getting because you started with that full honeymoon period. And now your, life gets in the way, you've had a lot of work, but you feel like those things aren't adding up. And for somebody who adds up a lot, I can tell you, they do. It doesn't take much. A lot of my experiments are very focused amounts of adding carbs for the purpose of gathering data. I'm still impressed at how long-lasting the downstream effects of them are. And I, of course, get to notice it a lot more because I'm actually tracking it.
Yeah, I usually do not recommend drugs for helping to keep the weight down. I think that, in most cases at least, the side effects are probably not worth the limited effects, at least for most people. So I would probably rather recommend adding something else if need be to a low-carb diet, like some intermittent fasting perhaps, maybe some exercise, think about sleep and stress, those kind of things. And then there is a prescription-free drug that can help people lose a little bit of weight called coffee. It's pretty tasty.
When I first started practice, I was an early adopter of new drugs until I had some near disastrous experience with patients, and then I began using the more tried and true drugs, and now I've kind of reached the point where I'm reluctant to use any drugs at all unless I can, as long as I can get away with doing that. So I wouldn't be one that would recommend drugs. And I've been doing this now for, 35 years. And I haven't been strict keto the whole time or even strict low carb the whole time. But I think the important thing for people who want to maintain is, if you fall off the horse, you've just got to get back on. You can't say, well, I fell off the horse, so I'm going to walk the rest of my life. People go out and they blow out a meal and they say, well, I've blown my diet, what the hell? I'll be face down in everything. And you just got to pick back up and get back on it and move on. And that's what I do. Every now and then I blow it out. If I go to France, I have croissants. When I come back, I go carnivore for a while. And I've got my own little system to maintain my own weight loss. And I think people maybe need to be coached on that or be told that if they do blow it out for a day or a week, that they can get right back on and get after it. And it's a marathon. It's not a sprint.
I just like to put in a plug for behavioral psychology, and I think there's a massive behavioral component that comes into keeping weight off long term, and it goes back to that cliched statement of knowing your why and constantly coming back to revisit it and knowing why you are doing what you're doing, and once you get good results, how good you feel, keeping that front of mind. I think you only need to look at, when it comes to sustainability, you only need to look at a previously uncontrolled type 1 diabetic who is now controlled and how good they feel, and how well they do by constantly knowing why they are doing it and feeling good.
Thank you.
Yes, ma'am.
Hi, Pat Joyner, dietitian from Monument, Colorado. And my question is about, well, let me start over. For about 20, 25 years, high-fat diets have been used to alter the gut microbiome in animal and human studies, and seems to increase lipopolysaccharide, increase the inflammatory cascade. And high-fiber diets have been shown to increase the incretin effect in GLP-1. So my question is how do we consolidate this dichotomy in studies?
Until there are specific studies among those who don't eat carbohydrates about the microbiome, I'm ignoring everything. Of all of the big distractors in the medical world, this is one. You can get funded to study the microbiome of children trying to lose weight at Duke University, and they have been funded to do that, but they won't fund a low-carb, high-fat diet. The microbiome, I've been in lectures and I do have a rational thing to say. The gut microbiome changes based on what you eat. And so I saw this beautiful picture at the meeting last summer the beautiful gut microbiome. It's like the beautiful flora and fauna of the forest when you eat carbs. And then there's this terrible desert of microbiome when you don't eat carbs. And I'm like, that's desert beauty. I mean, so it's like you're in this idea that something's different, it must be bad. And I've not seen any study yet that says I should change my practice other than change the carbs in the diet, because that's going to change the gut microbiome. And yes, I know the paper that says that the gut microbiome changes, so therefore it's bad on a low-carb diet. And so best I can tell is it's apples and oranges, or it's just not relevant yet. I'm watching, yes, the fecal transplants of different diseases getting better, which fantastic if it scales up, but it's kind of too early for prime time. And gosh, there are people selling probiotics with carbs in them that destroy what I'm trying to do. So I don't know how to use the gut microbiome information yet.
I think it's another case of these observational correlations where you draw very big conclusions, but you can't really do it. Like Eric said, as long as there are no studies showing that a low-carb diet results in some kind of bad outcome when it comes to health or well-being, I don't really care what happens to some bacteria.
Just on the microbiome, there was a study that came out just the other week done in China, and it was a randomized control trial, and it was low carb versus high carb, and the low carb, high fat diet had, the outcome was that it negatively impacted the microbiome. So of course the headlines went crazy. And actually when you look into the study, you see what they did was they defined the high fat diet as 40% fat. So I'll leave that to you to decide if that's really high. And the type of fat that they used was soybean oil. So I think that comes back to the research question and critiquing research. We need to look deeper than the headlines. But of course, the anti-low carbers came out and said a low-carb diet, a low-carb high-fat diet is detrimental for the microbiome. And I'm sure it is if you have 40% soybean oil, but not the way we know to be low-carb, high-fat.
All right, well, I got to make the tough call here. I was told 12:15 was the hard deadline here. Lunch starts, I guess, now. Appreciate all the questions. Maybe you can address those one-on-one here after we get through here, but I've got to let everybody go to lunch, and then we'll come back after that. So thank you very much. I appreciate everything.